great to be here. I'm going to talk to you about some experiences with what we used to call hearing therapy. Basically, I'm going to talk about the experiences I had beginning in the UK, and I first became an audiologist in 1971. And so don't be misled by my youthful appearance. I'm actually quite old. I was working in the British Health Service, and it was an interesting time. I came to Australia in 1980, and been here ever since. You might find that hard to believe because of my accent, but it's sort of this was a field I was very interested in the UK. When I came to Australia, my job was to run the audiology program, so my priorities changed a bit, but the contact with Hearing Matters has made me think a bit more about this again. So hearing therapy, well, I mean, what exactly I mean by that will come up in the presentation. I was appointed as an audiologist in the UK, and it was in a medical physics department, which is the way they ran things. But the thing about the UK at the time was that instead of as in Australia, where you have graduates who are trained in audiology, in the UK there were very few people who were like that. Most of the clinics were run by audiology technicians who were people with the TAFE sort of training. And typically it would be high school students would be appointed, and they'd do a course and they would fit hearing aids. The hearing aid service was very, very different from the service here. It was an over-the-counter service, so that you went in and you got your hearing aid almost like this, and a few words of instruction. And they were mostly pocket aids then. Children got behind the ear aids, but there were a fairly substantial hearing aid that was designed in the 1950s, and you either got one or you got a slightly more powerful one if you were deafer. And it was a fairly basic sort of service, but it had one advantage, that the hearing aids were free for everyone. There was no means testing. You were sent in by your doctor to the hospital, and you were given a hearing aid. But for me it was great because it was such an easy service to improve. And I looked to Australia because this was where it was all going on. That's an important thing to remember. Sometimes people don't seem to realise here how advanced Australia is in some areas. And this was a good example. So what happened was, there's a group of ear, nose and throat specialists in this little hospital in the north of England that just did ears and eyes, and they wanted an audiologist. And they were, I should always be grateful to them, because they were quite keen to improve the service. One of them was very interested in fitting children with hearing aids, and one of them was an otologist, very keen on complex ear operations, and the other one did throats. But they wanted to have a better service for the patients because they realised this over-the-counter business wasn't the way to go. So I was appointed by a medical physics department and seconded to this hospital, which was a good arrangement really, because I had the resources of a very big medical physics department, and I was able to get equipment and introduce new techniques. And the other point about this particular period was there was an MP who was deaf, and he had acquired a hearing loss later in life. I think it was as a result of something like meningitis. He'd been able to hear, then he'd lost his hearing, and it was quite a significant loss. And that was a real advantage, because someone in Parliament was pushing to improve the service. And it was really, Jack Ashley was his name, and here he is. And he did a lot of good. He was able to get things through Parliament, and the service did improve. I think it would have been fairly difficult without somebody like that. Now, what the UK government did was they knew that things in Scandinavia, the services were very good. So the UK sent a team from the Department of Health around Scandinavian centres to see what was going on, and they'd notice a big difference from what was happening in the UK. And I was fortunate that I was the first person appointed with the title of audiologist in the UK. There had been famous people who were working in, many of them in London and so on, who were scientists working in the field, and they were doing a lot of, research and were quite well known. A very distinguished professor of medical physics turned up one day and asked to be shown around the department that I had set up, and I told him what we were doing, and then I was invited to sit on a couple of Department of Health advisory committees. One of them was to improve the services for the hearing impaired, and the other one was to improve equipment. I did have some input into the way the services were developed, but I thought that I'd better find out as much as I could. I was fortunate that the department let me go to places to pick up information, and I spent a lot of time in London, in the big London hospitals where, it was patchy, but some places had really good services. And I was also able to get a grant to go to Scandinavia. I went round Sweden and Denmark for a few weeks, visiting centres and learning how they did things, because it was a much better service than we had. And I'll tell you a bit about it. It was a charity that we applied for a grant for. The aural rehabilitation was the phrase that was used. That suggests someone has been able to hear properly, has acquired a hearing loss, and they would need to be helped to cope with it. In Scandinavia, this was seen as a profession, and there were people who were hörselpedagog, they were hearing teachers who'd been trained to work with deaf children, and they had been retrained to work with adults. The other thing was that we had they had a system where, when the hearing aid was fitted, an engineer used to talk to the clients, and sometimes in groups, and they would also have instruction about how to cope with the hearing loss, and they would be shown devices to help them. They were getting 6 hours of instruction when they got the hearing aid, and it was regarded as perfectly normal that this was done. Things were better here, but there were some issues here too, but certainly it was a great contrast to the UK. Now, so this was in Fredrickson, who was a very capable chap working in one of the hospitals in Odense, and so the patient goes into reception, the history is taken, they go to a technician. They had the technicians too, and they would test people. They would go to an ear, nose and a throat doctor. They would have an impression made for their ear mold. They'd be given the hearing aid. They'd go to see the hearing teacher, the hearing pedagogue, and then they would be referred to someone in town for further rehabilitation. So that was the pattern, okay? And it was quite impressive. Now, this slide, it's showing some of the devices that were given out. So every time somebody got a hearing aid in Denmark, they were on average given 6 of these devices as part of the deal. So, you could call upon an agency who would come and fit them these devices in the house, okay? And we've got things like when somebody pressed the doorbell, all the lights in the house would flash on and off, okay? Or they would be something for the television. There'd be an amplifier for the television. Sometimes they put an induction loop system in the room so that this would transmit the signal into the hearing aid. And remember, in these days, no Bluetooth, so this was the best you could do. And it was, at the time, this was really up-to-date stuff. I felt that the people in Denmark were very fortunate. And in the hospital, they actually had rooms set up permanently. They had a living room. So You know, there was a section in the hospital where they had this living room, and there was a television and an armchair and a telephone. The telephone used to flash on and off. I don't know if any of you remember Batman had the bat phone in the Batman movies, flashed on and off when it rang. They could demonstrate the doorbell and they could show people all this stuff. And people would say, well, yes, I'd like this and this and this, and then someone would come and fit it, okay? So it was to try and make life a bit easier, and the hearing aids have vastly improved. But the principle's still the same. I think there are a lot of devices which people don't know about. The regular person who's just got a hearing aid wouldn't necessarily know about this. If their hearing loss is very severe, it would be quite useful. The other thing was, if you're very hearing impaired, and I've seen people like this, a mother with a very severe hearing loss. I remember this poor woman coming into the clinic, and she was wearing a hearing aid, and I got her to take it out so I could examine her ear. Her ear was swollen, and she was wearing the hearing aid 24/7 because she had a baby and her husband was at work, and she needed to wear it to hear the baby. Anyway, they'd set a bedroom up like this. They had this slide shows of a cot in a room, and there's a microphone over the cot, and when the baby cries, the microphone picks the signal up, goes through an amplifier, and it goes into a bedroom. And there's an alarm clock rigged up as well, and there's a thing under the pillow like a clamshell, and it's under the pillow, and when the baby cries or when the alarm clock goes off, it shakes and wakes you up. So this was a way to deal with that situation. Now, many people who come into the clinic in Australia have only, like adults, have only got a sort of fairly mild hearing loss. But, if somebody's got a really severe loss, these kind of devices were really handy. And they are available here, but, there isn't some sort of agency that's going to come in and fit them without a lot of, paperwork and knowledge about how the system might help you. The other thing was, I remember coming across a patient in the clinic in the UK, and it was a young lad who'd fallen out of a window, and he was in a wheelchair, so he was crippled. He'd hit his head and probably fractured the temporal bone, so he had a tremendous hearing loss. And he was someone who could, he could speak, he'd been able to hear, and it was devastating because suddenly he heard nothing. You're just seeing people's lips moving. We found out there was a centre in the south of England, and we got some money, and he went down there. But when I went to Scandinavia, there was a government-run centre at Fredericia, which was, it was a place where you went, and if you stayed there, you could stay there for weeks. Someone who'd lost their hearing like that could be given a lot of instruction and help. There would be lip reading instruction and sort of tips about how to deal with the hearing loss and so on. An example I used to give to the students was that if what you really want to do is to try and cope with the loss by tricks that you could, say you went to McDonald's, that's a good example. They're going to ask you what you want, and they're going to ask you, do you want it as a takeaway or a dine-in? So you would say what you wanted, and you'd give them that information so you didn't have to listen. And this is what these people did. They would tell you where to sit in a room so that the light was shining on the person you're trying to listen to. So lots of tricks and so on. And they would get them to listen to tape recordings of speech and try and repeat what was being said. And they would teach them, rather like hearing impaired children are taught by a teacher of the deaf. So they would have intensive work. And you'd say to someone, tell me when you hear the odd word out. Bar, 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 gar, bar, bar, bar. And they would indicate that they'd spotted, and they'd practice this kind of thing. It was most impressive, this, and it was a nice place. These were the people who were sent there. But it was quite a cute looking building. These are old slides from years ago, things that I got when I actually went on the trip in the 1970s. On to more recent times, a famous audiologist called Arthur Boothroyd, who lives in the States now, used to be at the University of Manchester. He has written about the need for this kind of aural rehabilitation, this follow-up work when a hearing aid's fitted. You know that some help's needed, but a lot of people don't know. So Boothroyd, he's thinking about the problems that you get because of hearing loss, the quality of life changes that take place. You know, I can remember being at the predecessor of this organisation was Self-Help for Hard of Hearing, and I remember a group meeting where there were a lot of hearing impaired people in the room and someone who was really, really deaf, and they were just out of it. You know, the speaker was talking, people with a moderate loss could hear him okay, but this person was, you know, they might as well not have been there. They were not getting the information, and this is sort of what happens. I went with a colleague of mine who's suffering from dementia, and I went with him yesterday to see an audiologist because I'm now retired, and I took him in to see an ex-student who was great, and they tuned up the hearing aids so it was reproducing speech in a very accurate way, as well as it could be. Well, what we need, I think, is to have more after we fit the device. There would need to be a sort of follow-up, some sort of attempt to find out what the patient needs apart from the hearing aid. And Boothroyd's a very influential figure. He wrote this because he felt that he knew a lot about fitting hearing aids and so on, but he was trying to point out that we need more than that. And audiologists tend to focus on fitting the hearing aid. They're not thinking about the other stuff. He's saying there's a disconnect between the results when we're sort of fitting the hearing aid and what the patient thinks, okay? And the problem is that the financial side of things is often sort of dictated by fitting the hearing aid. That's what people get paid for, you know. Say it's a commercial situation, a private audiologist would fit the hearing aid and get paid to fit it, but they don't get paid to do follow-up and this further help. You know, that's just the way the world is. And in Scandinavia, because of the extremely high rate of tax and the efficient way that they use the money, they actually provided a service that was more than just giving the hearing aid out. It's a bit of a paradox. So there's some indications that this is very important for some patients to have more help after the hearing aids have been fitted. Now, what happened back to the UK was in the 1970s, this MP is pushing, and there was an organisation, very old-fashioned name. It was called the City Literary Institute, and they used to train speech pathologists. And I was always rather amused because whenever you met a speech pathologist who'd been trained there, they always sounded exactly the same. They had done elocution, so I worked with someone who would, come from the UK to Australia, and she sounded just like Jennifer Saunders because they'd both been trained at the City Literary Institute. And the City Literary Institute, though, was actually quite progressive. They took on the job of training people to do this hearing therapy, aural rehabilitation. And they set a course up. It was just a year's course. I was on this committee that set up the grade in the UK, so there were going to be hearing therapists appointed by the British Health Service, and the first year there were 4 of them, and I managed to get 2 appointed to my centre. We interviewed people. One of the ones that we had was a teacher, and the other one had been an audiology technician, and they went to the City Literary Institute, did this course, and it was quite impressive. It was short, but at least it was a vast improvement. And they came back and worked in the centre. But what happened then, in the fullness of time, in the UK, the audiology technicians have been replaced by audiologists. So gradually, there are more qualified people doing the work in an audiology clinic in the UK. And sadly, they've stopped appointing hearing therapists because they said, well, the audiologists can do it. Which is very sad, because if you're appointed to do a particular job, then the chances are you'll get on with it and do it. But if you're appointed to be an audiologist and fit hearing aids and do the hearing therapy, there's a danger that you might start focusing on just fitting the hearing aid and perhaps not emphasise the other stuff. I was disappointed to hear this. This was one of the City Literary Institute's teaching aids. They're sort of thinking about the hearing therapist in the middle and family and counselling and all the sort of things that they would teach. They'd teach lip reading. They would tell people about hospital services. They'd tell them about hearing aids. Remember, often people don't know that services are available. So this is the sort of stuff that they would do. They would review the features that were available in hearing aids. They'd help people to understand the nature of the loss. Sometimes, the clients think that they'll get the hearing aid and they'll just hear normally again. Okay, I once went to a lecture in the Philippines, a training course for teachers of hearing impaired students, so the teachers of the deaf. What distressed me was I was talking to the lady who taught them about hearing aids and cochlear implants. I said, of course, the cochlear implants are great, but there's a very limited, auditory information. It's very useful. But she said, oh, I thought they could hear normally again when they were fitted with cochlear implants. And she was training teachers. And, I thought this was distressing. But, the people might think, and I've come across someone who was referred for a cochlear implant and was told repeatedly that they would not be able to hear normally. How have you gone? I said, and they said, oh, I was terribly disappointed. They were hoping so much to be able to hear normally again. They didn't pay any attention to what anybody said to them. So we need to tell people about the nature of the loss and so on, and how to get the best use out of the hearing aids, counselling people about hearing loss and so on. And training them. Teachers of the deaf go through procedures with children to get them to improve their perception of speech and so on. So this was it. Hearing tactics, remember McDonald's, you try to avoid a situation where you can't cope by taking the initiative. Lip reading instruction. There was some debate about whether you could teach people to lip read. Some people can do it naturally and so on, but I think an attempt to improve matters, it sort of seems like a reasonable thing to do. In those days, there were a lot of signing deaf people, and it was it was important to sort of explain about this. Probably now that in Australia there are many more people fitted with cochlear implants, the signing deaf community might be shrinking a bit, but they're still out there. The picture of the guy, not being able to hear the telephone is out of one of the Scandinavian publications. So we unleashed these two young ladies went off to do the training program in London. When they came back, I had this patient called Mr. W who used to come in and see me. I'd fitted him with very powerful hearing aids. He'd acquired an immense hearing loss later in life. I did the best I could. I always made him feel welcome and I talked to him and so on. But the poor chap was devastated. Nowadays he would have had cochlear implants. But, and it was causing problems at home. His wife was obviously, having difficulty communicating with him. Anyway, these two young ladies got at him and they really gave him a good going over. And I sort of was amazed when I saw him again. He was more confident. They had really done a great job, so I was a believer then. This was quite impressive. He was communicating better. he was looking at your face, he was obviously attempting to lip read, and he was able to use the auditory information he'd got. So it was quite impressive. His wife was, delighted because life was a bit easier. It's not that he didn't have any problems, but they were able to sort of work on him using what they'd been taught. Now, I did actually, egged on by the ear, nose and throat specialist I worked with, suggested an experiment where we took the people who'd been fitted with hearing aids and tried to assess how well they were coping, a sample of everyone who'd come in the clinic over a certain period. And I gave them speech tests and we interviewed them and so on. And it was pretty intensive. We had them going to different sections because by that time we'd got funding for quite a big department, and they were sort of various aspects of how they were coping were checked. What the ear, nose and throat specialist thought was that some people would be managing quite well, so we don't need to worry about them, but others would need more follow-up and help and hearing therapy. But what I found was that the results were surprisingly bad for practically everyone. And I remember giving a presentation at a conference and saying that, this service is not very good. We're giving the hearing aids out, and we need to do more than that because the hearing aids are not helping people enough. And a famous person stood up and said, I think this is nonsense. I give hearing aids out. We give hearing aids out in our clinic, and people are very glad of them and do wonderfully well. And then what happens at conferences when that occurs is the wolves move in. Everybody starts criticising you, and you go down under. And fortunately, another famous person at the back, who actually works in Australia, he stood up and said, yes, we found the same sort of thing. So I was saved, and it was, I'm simplifying this. It's not that the hearing aids weren't doing any good, it's just that they weren't they weren't helping the patients as much as the patients needed help. So the other thing I did was I copied another famous scientist working in the field of audiology in the UK called Brooks, and he was a bit of a mentor. And what he did was he ran a training program for volunteers, and he had the area he worked in split up into squares, and in each square he had a volunteer. So the map of the area he worked in was divided up, and he had someone in each square, and they went round when somebody was fitted with a hearing aid. They went round after the hearing aid fitting, visited the person at home and said, how's it going? And they had a set of questions they would ask. They'd get them to put the hearing aid in, they'd get them to switch it on, they would get them to change the battery, and often they couldn't do it. So I repeated it. If they were in trouble, we got them to come back to the hospital. And this was very unpopular with some of the audiology technicians, because they'd fitted the hearing aid and they just wanted the people out of the door. So that was interesting too. But there were people who, with this quick over-the-counter service, it was obviously not the way to go, because the hearing aids were being left in a drawer and not used. So Scandinavia was a big plus. One of the reasons I came here was I was very interested in fitting children with hearing aids properly, and there was a way to do it. The Burn and Dillon procedure, and I was told about this by the headmaster of the school for the deaf, and we started to do it in the UK. So we were copying the way Australians fitted children, and it was really a far better method than what we'd been doing before. It's been a great area of strength. Hearing Australia, they were doing a great service for children and means-tested pensioners, but however well they did it, there's a hole in the service because people weren't eligible. And also, the service for children was absolutely outstanding. The one for adults, I remember talking to one of the local audiologists about all this, aural rehab and having the devices to demonstrate to people, and there was a feeling that, oh, we're doing that, but of course, that wasn't the case, and there were people in the organisation who realised this, and I don't want to sound too critical of Hearing Australia, because they were doing an awful lot better job than was being done in the UK. It seems generally around the world this kind of follow-up is missing. Now, there are ways that we can check how things are going. Dylan, who's the famous scientist here working in audiology, absolutely outstanding international standard sort of person, and he came up with various schemes to try and assess what difficulty people were having, and the audiologists didn't like some of them, but one of the ones that he developed and the audiologists went for was called the COSI, which is a sort of simple questionnaire that you give people at the end of the fitting, and then you give it them again after a few weeks when they come in to see how they've been going. So there's an attempt being made to see how they are coping with their hearing loss, and there's a new version has been developed, is soon to be introduced, and things have improved with the hearing aids. The hearing aids are cleverer. If I'm at a dinner party, I can hear what's going on, and now that hearing aids are being introduced with AI, which is even more sophisticated. I mean, there are limits to what can be done. We do have cochlear implants now, thank goodness. But they are great, but they are limited as well. The problem with cochlear implants is they're very expensive. When we do this, we go to Samoa and do voluntary work. We saw someone on a last trip who was an 8-year-old who was blind in one eye and partially sighted in the other, and really severely deaf. My wife was able to test his hearing. He should have been implanted, when he was a little baby, and there was some reluctance to take him on now, because the Australians are so used to fitting babies that they're not too keen on fitting an 8-year-old because the results are not going to be as good. However, the main thing is that they're so expensive. The cochlear implants are out of reach for many people. So although things have improved vastly here, think about the situation in developing countries. If you've got a device that costs $25,000, you're not going to find them fitted to every child like you find in Australia. Again, this is a thing to be very proud of here. We have had support for the work we're doing overseas from Cochlear. So what's happening is we've got to focus on hearing aids, and we need to think about the other things that are useful. This is the COSI scale. You sort of ask them what their needs are, like I can't hear television, or I can't hear when I'm in a crowd, and you fill the form in. Then you record that, and then you get them back a few weeks later and say, how's it going? Okay, can you do this? And there's you've got sort of like the responses are almost never, and they're sort of an attempt to assess what is happening to them in the real world. There are a number of publications about aural rehabilitation. There was debate about whether the rehabilitation work should be done one-to-one. I've fitted you with the hearing aid, you've got the hearing aid, you're talking to me about your needs, and I'm talking to you about how to cope with the loss and so on. Or can we do it in a group? And the Scandinavians were doing it in groups, and it looks like that's quite effective. So, I was inclined to think better to be one-to-one, but in fact this study seemed to show that you could get quite good results by working in a group. This is a paper where they were looking at the problems that people have even when they've got a hearing aid, and how important it is to try and improve matters. The American Speech Hearing Association, a giant organization in the States that was involved in speech pathology and audiology, they came out with a set of guidelines. They were keen on the speech language pathologists, collaborating with the audiologists, and thinking about the impact of hearing loss. So they were saying there was some sort of appropriate guidance being given, and so on. So the organisations and the research are indicating that something needs to be done. But I think we've still got a gap. You know, there's still stuff that's not being done. The money's for fitting the hearing aids, and it's a bit like one of the surgeons who was appointed a few years ago in Australia was talking to me. He does the most amazing ear operations, and it's cutting edge stuff, and he's collaborating with these famous American universities. But when he got the job, the hospital administration people wanted him to improve the number of tonsils that were taken out. They were looking at numbers, how many tonsillectomies have you done? And he's doing these operations where he's removing tumours from the acoustic nerve and things like this. So, you have to watch out that in the UK there were waiting lists for fitting hearing aids were very long, and the idea was to get the patients in and get the aid onto them and out of the door. And so you have to watch out. There's that kind of pattern. There isn't as much information given to people about things like assistive devices and so on. There are much better assistive devices now. The Roger Pen is a good example. Is a great device, but you have to know that it's available. And there's certainly been funding for veterans to get them, for example, and they can be used in noisy situations or with the television or whatever. But it's a bit sad in the overseas locations because they're expensive. There are many people here who wouldn't know about them. And what I think we need to do is to review the outcomes of the hearing aid fittings. We need to revisit that. It would be good to see research on the people coming out of the clinic, and then to see how they are coping in the outside world, in order to try and indicate that more work needs to be done like this. And Dylan told me that he had managed to get some, under the Office of Hearing Services scheme, the scheme to give free hearing aids to pensioners, he'd put a couple of items in which were to do with rehabilitation. And they're actually there in the documentation. You would do them and you would get paid for doing some, aural rehabilitation, but you don't get paid very much. And I think possibly the audiologists might be tempted to fit someone else with a hearing aid rather than doing that. At least he's got something down on the list of jobs that you can get paid to do. But I think there's still, even now, there's a need for more work after the hearing aid's been fitted, and that's really one of the functions of this organisation, is to try to help people with that kind of follow-up post-fitting, and they're sort of to try and improve the ability for people to cope in the real world with their hearing loss. Okay, that's it. Thanks very much.